Right.
This one?
Yes.
Warm greetings. Thanks, Dr. Ashish and team AOIOR for giving me this opportunity. Well, speaking in favor of conventional arthroplasty at a center of excellence in East India is, my situation is nothing better than a Ukrainian government right now. Anyways, I have to do my job. So once I was given this topic, I got an online survey that how many arthroplasty surgeons in India are using robot. To your astonishment, you will get to know that more than 90% of arthroplasty surgeons in India don't use robots. In another survey in which we involved postgraduate trainees also, 95% of postgraduate trainees as well as arthroplasty surgeons haven't seen a robot yet. So, to start with, grass is not always greener on the other side. There have been many technological advances such as computer navigation, patient-specific cutting guides, custom patient-specific implants in the adult reconstruction arena in recent years. Robot is today not the first to be used. It was used about 38 years back in 1988. First time. It has got many systems, many types of robots which are passive systems which completes a portion of the procedure under continuous and direct control of the surgeon. The active systems perform a task independent of any surgeon involvement, and there are semi-active systems which require surgeon involvement but provides feedback. Semi-active systems are also known as haptic systems, and it was well elucidated by Dr. Nisikant in his talk. So steps to a robotically assisted replacement surgery typically involves creating a patient-specific model and interventional plan, intraoperatively registering the model and plan to the patient's anatomy, using robotic assistants for bone cuts and carry the pre-operative plan on the patient. Many robotic systems have been developed and prototyped, but only a handful had been successfully used in clinical settings. Let's see what evidence says, not what eminence says. There are several reports to show improved precision of implant positioning in total hip arthroplasty, total knee arthroplasty, as well as unicondylar knee arthroplasty for robotic assisted surgery compared with conventional techniques. Each of them shows better implant position, but is the hype justified? As new technology continues to be incorporated into practice, it is imperative to examine the reproducibility, precision, and accuracy of these advances, and not only these, as well as the long-term clinical outcomes. Regardless of the improved precision of robotic-assisted surgeries, it is important to determine whether the improved precision will impact functional outcome and implant survivorship. Improved clinical outcomes are needed to justify the added operating time, integration into the surgical flow, and increase its direct cost resulting from the application of robotics. We should not forget that we are still living in third world country. Given the novelty of robotic technology and limited market penetration, there are relatively few published articles on the same. As new robotic products are introduced across various platforms, many surgeons find it difficult to parse out marketing claims from reality. So these are the various robotics used in total hip arthroplasty with an advantage of femoral broaching and stem implantation. It improves accuracy and precision, there is no doubt about it. Robots have the capability to accurately place acetabular components well within the safe zones. It has the advantage of minimizing limb length discrepancy. It has the advantage of bone stock preservation, but it has certain inherent disadvantages which we cannot neglect. One is the financial implications. Robotic systems have high front-end costs due to investments. Navigation software for robotic systems also require a pre-operative CT scan, which imposes an additional cost as well as radiation hazard, and cost of additional disposables are also tremendous. It has got an inherent increased operative time and learning curve, and training of specialized staff also needs that are there in the operating room. What about complications? The literature shows at least about 15% of failure rate due to technical complications requiring manual implantation. There is lack of long-term outcome data. So the critical question is, how does the improved accuracy translate to better clinical outcomes? Is it worth the extra money? Is it worth the extra effort? Is it worth the extra time? Considering all the disadvantages and the costs involved, there must be clear benefit to the patient in terms of functional outcome to justify the use of robotics. Currently, there are insufficient studies with long-term follow-up outcome data evaluating robotic surgery. Recent meta-analysis by me and my team, it interprets robotic assisted arthroplasty leads to highly accurate implant placement and leads to significantly reduced limb length discrepancies. However, we do not recommend robot assisted techniques for routine total hip arthroplasties due to lack of adequate long-term follow-up data, prolonged surgical times, and no significant differences in the rate of complications and implant survivorship. This is level 1 evidence. We don't need anything more than this. Robotics in knee arthroplasty has been able to achieve a more consistent post-operative prosthesis alignment as a result of ability to employ individualized distal femoral resection angles, precise femoral component rotational alignment, accurate bone cutting. Other than those mentioned for robotic THA, robotic TKA has some additional drawbacks. Preferred robotic system of a surgeon may not be compatible with the preferred implant system. Incorrect registrations can lead to disasters during surgery, and these systems still lack the ability to make creative decisions. So the list is long. Meta-analysis suggested no significant differences in functional outcome between robotic total knee arthroplasty and conventional manual total arthroplasty. We all are scientists here. We should know the scientific evidence, and then we should try to incorporate the results into our final practice. So the final verdict is, robotic surgery may be preferred by young amateur surgeons who carry out low volume arthroplasty, that is less than 30 surgeries per year, as the increased accuracy would minimize the error during implant positioning in inexperienced results. This is the meta-analysis published online just 2 months back in the month of June. Experienced surgeons routinely get good long-term clinical outcomes using conventional methods, and robotic techniques do not offer them any clinical added advantage. So robotic arthroplasty associated with increased surgical time, learning curves, and added financial costs. This is what the literature has to say. Thank you. Thank you all for patient hearing.
Thank you, Vishal. Thank you, Vishal, for nice talk. Any question from audience?
Thank you, sir, for the excellent presentation. I would like to call upon Ashok Singh, sir, to felicitate the speaker and the chairpersons.
There was a time when there was no mobile phones of this type, of the present scenario. There was pager, it was started. But later on, how advancement has come in this world of robotic and many other navigation system. So actually, I think it's a blind man touching an elephant. So a time will come definitely when we will be very well versed, and as another generations who will think it will be very helpful. Thank you.
Thanks, Dr. Vishal and Dr. Nishikant, for nice presenting. We learned lots of things about navigation and robot system. With this, I am concluding the session with thanks to all.
वो सेपरेट हुई थी